Good morning and welcome to the WPS Government Health Administrators Evaluation and Management Time Question and Answer webinar. The purpose of this webinar really is to allow you to ask questions. We do have a presentation that we're going to go through. We will be going through that fairly quickly so that we do have time for your questions. We took a look at the pre-submitted questions also. And we received several that are not going to be included in this presentation. Some were on telehealth. We're doing a telehealth presentation on March 22nd. You can certainly sign up for that. Just as an FYI, for 2024, you do want to use the 02 or the 10 place of service without the modifier when you're doing telehealth. We also received pre-submitted questions on shared and split. We have included this information in our previous webinars for when this applied, which is for facility settings. We have those presentations available on our website under the Training Center and under the Encore page, and then it stays out there about 90 days, and then it is available on our YouTube channel. And we have a playlist for both Encores and for evaluation and management services. If you believe another or a separate webinar concerning that topic would be appropriate, please include that within your survey. We have been doing evaluation and management series on these for quite some time, and we divided these up into categories. So office, inpatient, skilled nursing facility, etc. And those are also available on our YouTube channel. We always provide this disclaimer because Medicare rules and regulations do change often. If you've been involved with Medicare for any length of time, you know that things change. CMS rulings and regulations that are available on their website are the final determinants of coverage. And for evaluation and management, your documentation really plays into whether Medicare can support the procedure code and the level of service that you have submitted. We are going to respond to questions, and we'll respond based on the facts that you're giving us within the question. However, again, Medicare rules and your documentation determines that final coverage. CMS does prohibit recording of this presentation for profit-making purposes. We are recording this presentation, and barring any technical difficulties, we will be placing this on our website under the Encore page, under our training center, and then also in YouTube, again, both in the Encore playlist and the evaluation and management playlist. So if you are recording or doing screenshots or anything else, we would request that you stop doing that. We did have a pre-submitted question on what documentation you would need in addition to your time. Your medical record, of course, must support the medical necessity of your service. And then you would need to show how you spent that time, either face-to-face, or you can also include your non-face-to-face services, which I'll show you those qualifying activities here in a second. Your documentation must show that you have performed an E&M, medical appropriate history and exam, and then the medical decision making. The next thing we have are just some acronyms that we have used through the presentation, and we just provided this for you as a resource. So the first thing we have here is the medical necessity. You can see from the Social Security Act that services must be reasonable and necessary to treat an illness or injury or to improve the functioning of a malformed body member. I apologize for that. I'm suffering the effects of a cold today. All of this is going to be based on your documentation, what you're doing for the patient. Why does the patient need the services that you're providing? When the Medicare Administrative Contractors Medical Review Area or the Comprehensive Error Rate Testing Program or other Medicare contractors are reviewing your documentation, the medical necessity is one of the first things that they're going to be looking for. You want to make sure that your documentation supports that. Why are you seeing the patient on that particular day? When using time, the determination of the procedure code is pretty straightforward based on the documentation supporting the time that has been spent. Verify that your practitioners are capturing all of that time, both face-to-face and non-face-to-face time spent working for that patient on that date. You don't want to leave money on the table. You want to make sure you're capturing all of that time. You can see here that the American Medical Association owns the descriptions of the procedure codes. CPT is not a CMS or WPS document. Where CMS rules differ, and they do differ in some cases, we'll do our best to point those out. As you can see above, the AMA made changes to the office or other outpatient services in 2021, and the other categories of codes changed in 2023. The major change was in choosing your level of service. You can use time or medical decision making. The choice of how you choose your level of service is really up to you, whether you want to use time or MDM. Neither one of those are required by Medicare. So in your practice, you can choose to use time only. You can choose to do medical decision making only. You can choose, for this patient, I'm going to use time. For this patient, I'm going to use medical decision making. That's really your choice. You want to choose your level of service and choose the way you choose your level of service based on which one is more advantageous to you. If time allows you to submit a higher level of service for this encounter, then use time. If medical decision making allows you to use a higher level of service, then use your medical decision making. You can see here the exception. The emergency department does not use time. It is MDM only, and critical care only uses time. So we've provided information here for you on your levels of service. This is just what's in the CPT. And then that last bullet point, you must meet or exceed the time as listed in the code description. One of the things to think about is coders and billers can only code based on what the practitioner has within that documentation. If they don't tell you how much time they have spent, if they don't tell you what are the activities that they spent that time on, then you really need to go back to them, not only to educate them, but also to get the information. One of the pre-submitted questions we received was, do we have to use one or the other? Or does the MDM trump time or time trump MDM, etc.? And the answer to that is no. You do want to use the one more advantageous to you. Another pre-submitted question we received was, well, what if we miss a time by 2 minutes? Can we still go ahead and bill that higher level of time? And the answer to that is no. You must meet or exceed the time as listed in the code description. So using time to choose your level of service. The time is spent on that calendar date. This can include both face-to-face time with that patient and then non-face-to-face time in qualifying activities, which again, I'll show you in just a second. When documenting time, it's really better to document a specific time, not a range of time. We know that providers in some cases have different macros and things like that built into their system. But you really want to be specific in the time spent by that practitioner on that particular patient care. Time provided by the nursing staff, etc., would not count toward this time. Now, we're not asking doctors and practitioners to necessarily stopwatch themselves, use a timer, but the time spent does need to be shown in the medical record. In addition to that, CMS has information in the instructions to the MACs to review for accuracy of time. Well, what does that mean? Well, that means that if your physician or practitioner has documented, 45 minutes with that particular patient, the documentation needs to support 45 minutes. So that means someone else looking at that documentation can see that 45 minutes it would be supported by the documentation itself. If the only thing in the documentation is, hey, everything is going great, no changes, that's not going to support 45 minutes. Another question that we received was, do you have to sign on the same date, sign that medical record, in order to count the time? And the answer to that is no. You count the time spent on that calendar date. Now, when your practitioner signs that on a later date, of course, that time would not count toward the encounter itself. If you're doing a split shared service, you can count the time of both practitioners as long as both practitioners are documenting time. That also includes going for prolonged services if it meets those particular guidelines. Well, what do you do if one provider in a split shared service does not document time? Well, unfortunately, you're going to have to evaluate the documentation to determine if the time documented by one provider would give you a higher level of service than using the medical decision-making documented by both. And then another pre-submitted question is, can the physician carry forward a time statement for each subsequent hospital visit? Well, I think if you think about that particular question, you know that the answer is no. Each visit needs to stand alone. Today's service for that subsequent inpatient patient is not going to be the same service as it was yesterday. So the time that that practitioner spends may not be the same. You need to be specific as to what time you have spent. So here are the non-face-to-face time qualifying activities. And you can see here preparing to see the patient, review of any testing or anything that's been going on, performing that exam, counseling that patient, ordering medications, etc. Again, this is non-face-to-face time, but you want to educate your physicians and practitioners to notate this time. This is work that they're providing for that patient. Therefore, if they have documented it, you can count that toward the time. Other items are listed here, referring and communicating with other healthcare professionals. The next bullet point is very important, and you want to get your physicians in the habit of documenting this. If they're entering information within the medical record, that counts. If they leave the patient's room and they spend time dictating what just happened within that patient's room with that encounter, that time counts. But if it's not documented anywhere, then of course it wasn't done. Um, and then you'll notice on here, 3 of these bullet points have when not separately reported. These 3 things do have procedure codes where you can independently report this particular service. But if you're reporting that service, such as the interpretation of a chest x-ray, if you're independently reporting that, then you don't count that time. In one of the previous sessions that we did, we identified some documentation where the provider gave us time, but they did not split out the time for a separate surgical procedure code, minor surgery, that they did on that same date. Well, since they didn't separate that out, we didn't know how much time was spent on that procedure versus how much time was spent in that E&M service itself. Another pre-submitted question is, can you count time spent in talking with other practitioners? And the answer to that is yes. And then the question went on when it did not happen on the same day. And the answer to that also is yes, but remember, you're going to have to hold that claim. So let's talk about that example. Doctor primary care physician initiates a conversation either through text messaging, through email, through something like that with the cardiologist. The cardiologist doesn't get back to him on that same day, gets back to him on the next day. Okay, so you can still count that time that you're spending in having that conversation, but you'll have to hold that particular claim in order to count that time. The next slide that we have are services that you would not count. Travel time is listed on there, performance of services separately reported, etc. So here are just some examples of CPT codes. And you can see there that we've underlined how many minutes go along with that. So for the 99202, 15 minutes must be met or exceeded. The 99232, 35 minutes. And the 99307 is 10 minutes. And then, of course, here's the separately reported, and this goes back to that that piece of documentation that we had gone through previously. You have to separate out that time. As we talked about, the MACs are going to review for that accuracy. So if you have patients and practitioners that engage in other conversations, fishing or books or, what is Medicare up to now, that type of thing, your practitioner needs to exclude that time because that's not going toward the medical necessity of the service that's being provided to the patient. Pre-submitted question again, how do you count the time when the practitioner is spending it on other billable services? Well, you need to identify that within the documentation itself. One of the things that we have seen is, and I quote, time does not include time spent on other billable activities, end quote. That's really not the best practice. The best practice is to break it down. I spent 20 minutes interpreting the chest x-ray. I spent 15 minutes on the evaluation and management service for the patient. So what really does Medicare expect? Well, we need the documentation to support the level of service that you have provided on that day. We're going to be looking at, both us and the other medical review contractors, we'll be looking at documentation to verify that the time that is notated makes sense for what's in the medical record itself. So we'll be looking at activities documenting, asking whether it makes sense, etc. Another pre-submitted question, what do we do with documentation that states the time includes ordering tests, but the documentation doesn't indicate any tests were ordered? Well, this is another example of those macros, that standard language. Providers, physicians, practitioners, and others are responsible for their documentation. Canned statements, such as this one, can be a time saver, but if it's not accurate, then it really didn't do anything for you. If we're looking at the documentation and we see that statement, but there's nothing in the medical record, we are more than likely not to pay attention to that time that's documented there. So now we'll go through just briefly with the prolonged services. And again, all of this information has been included in other presentations that we have done. This is the information on the prolonged procedure code G2212. You have to exceed the time of that procedure code, excuse me, by at least 15 minutes in order to submit it. If you're using multiple units of that G2212, it has to be a full 15 minutes. And so this particular chart is from the CMS information and gives you the time required for reporting each of these procedure codes. We are aware that CPT has changed some of the time descriptions for 2024. We are not aware of whether CMS will change the information in this chart. They have not as of today. You want to watch for any changes within the CMS publications and within the CMS Internet-only manuals. The next one that we have is prolonged care on inpatient. Again, it works the same way. You have to meet or exceed that original procedure code based on 15 minutes or more. And for all the prolonged care codes, you have to exceed the top level in order to be able to bill that. You'll notice on here that for inpatient services, it does work a little different. The first two are on the same date, but the third one, the discharge management, is the date of that visit up to 3 days following the encounter. Now, with these and a couple of other ones I'm going to show you have that same type of language. You have to meet the procedure code time on the date of the encounter. The prolonged care time can be within this range of dates for inpatient up to 3 days following. And then for nursing facility services, you'll notice on here that when you look at the chart, it's 1 day before the date of the service and then 3 days after. And the same thing holds true. You meet the time requirement for your procedure code on the date of the encounter. Any additional time to meet that prolonged care service can be done the 1 day before or 3 days after or on the date of the service. And then we have prolonged for home services. Again, it's the same thing. You have a threshold of time to meet, and this one is 3 days before the date of the service and then 7 days after. Now, we understand, and we read the CPT book also. CPT description for the 99345 is 75 minutes. And for the 99350 is 60 minutes. However, what you see up on your screen is the information from the CMS manual. So this is different from CPT guidance as far as the time that you need in order to meet that threshold. CMS has not indicated to the MACs that they plan on making any change to that threshold time. So in order to build that G0318, you do have to have at least 140 minutes. Just some additional information. We've got critical care listed there for you. Again, in order to build that 99292, it is a full 30 minutes, not just a couple minutes, not the halfway point, a full 30 minutes for that. One of the big errors that we see and that providers request appeals on is the discharge management. There's no time documented, and they're billing the 99239 or the 99316 procedure code. Well, you have to have past that 30 minutes and then each additional 30 minutes for those two higher level codes. You want to get your practitioners in the habit of documenting time when they're doing that discharge management. If there's no documentation of time and you bill the 99238, for an example, will allow that, your best practice really is to document your time. You don't want to leave money on the table. If your provider really is doing that each additional 30 minutes, you want them to get paid for that. The next thing that we have then are just your resources, which includes the Evaluation and Management Services Guide. This is the CMS publication, that internet-only manual publication, and then that section 30.6 that contains 95% of all of the instructions on E&M. And then we have the Social Security Act and then the AMA information there for you. So the next thing that we're getting ready to do is open this up for questions. And before we do, we've got another couple of pre-submitted questions. One is, how do we count time over a midnight? So my understanding of this question is that it is a continuous service, and that's a requirement. So you start taking care of this patient at 11:30 and you end that encounter at 12:30. Because it goes over midnight and it's a continuous service, you gather up all that time and you bill based on when the service started. So that data service that it started. It must be continuous, meaning that there's no break in care. If you start the service at 11:30, your patient is, you take care of the patient, you stop at 11:45, you now need to go back to that patient at 12:15. There's a break in that care, in which case you have 2 dates of service and your time would have to go for each of those individual dates. One other pre-submitted question that we had, the primary care physician noticed an abnormality on a post-acute hospitalization chest x-ray. The physician did not see the patient, but did spend time on the phone with the patient and the surgeon to get the patient readmitted. What do we do in that situation? Well, you can't submit an E&M code because there was no face-to-face service, either in person or telehealth with that patient. However, for right now, you can submit the 99441 through 99443 telephone procedure codes for the time spent on that patient on that date. As long as that care is not originating from an E&M in the previous 7 days or one at the soonest available appointment. So we'll go ahead and open it up then. Rachel will take a look at the questions that we've been sent, and we'll go through those.
All right, let me just see where we're starting here. All right, so I'm just going to start at the bottom and go up. So can one provider document time for both providers who participated in the split shared visit? Example, the physician documents I spent 30 minutes, and then the NP spent 30 minutes on this encounter.
The answer to that is no. Each physician would need to document their services themselves. They don't have to repeat information that's already within the medical record, but especially when we're talking about time, both practitioners would need to document their time. Next question.
All right. For referring and communication with other healthcare professionals, can you give an example of when not separately reported? Can you give an example of when not separately reported for this statement?
Sure. There are procedure codes for interprofessional consultations, and these are discussions between the two physicians or the practitioners involved in that patient care. The patient is not present, but because of that interprofessional consultation, you can build that procedure code separately. And I don't know the procedure codes right off the top of my head, but if you're going to build that interprofessional consultation code separately, then any time that you spent on that, you would not include in that patient encounter. Next question.
All right. Per CPT Guidelines 99239 states more than 30 minutes on the date of the encounter. Does CMS require at least an hour to bill this?
No, we do not. And that's one of the codes that's different from having to meet or exceed. If you're doing your discharge management, the 99239 procedure code, and you have spent your documentation shows your practitioner has spent 35 minutes on that patient, you can use that 99239 procedure code, but we need to have the documentation for that. Next question.
All right. Did you say that you could count time the next day as long as the claim is held until discussions are completed?
Yes, I did. It's still part of the encounter. And I realize that sounds a little weird, okay? But as long as your physician or practitioner has initiated that conversation with that other practitioner on the date of the encounter, you can count all of the time that goes along with that discussion. But yes, you would have to hold your claim for that.
All right. If the physician documents that they spent more than 25 minutes, is this acceptable to bill 99213?
Okay, I don't have the procedure codes in front of me. I'm going to assume that 25 minutes has to be met or exceeded for that level of service. If that's the case, you can use that. It's not your best practice. Because again, that sounds like a macro. It sounds more like automated language as opposed to language that goes along with the service itself. Now, I want to make clear that I'm not telling you that macros and that kind of thing you can never use. What you want to make sure, though, is that it is accurate. Again, we talked about the CMS has instructed MACs that when they're reviewing evaluation and management services and it is billed based on time, we have to verify the accuracy of that time. So again, the example I gave, everything's fine, no changes, and that's all that's in the documentation. And I realize that's an extreme example, but it doesn't support that 25 minutes. And macros, those things that are built into your system that the physicians can click on and add information to the medical record. Again, that's not a bad thing, because we want to reduce the provider burden. It just has to be accurate. Next question.
All right. Next one is about time as well. For time statements, what is the best statement to use? Can we use something simple like total time spent, X, Y, and Z?
See, that's a great statement. Total time spent was 47 minutes or 35 minutes or, whatever it is. You want your documentation to support that. And then you also want your documentation to really, well, let me say it this way. The best practice is to identify the activities because, again, non-face-to-face time counts also. So, if your practitioner spends 10 minutes reviewing the latest lab tests before they go into that face-to-face with the patient, where are they counting that time? Because that counts. And that can go into choosing your level of service. So when Medicare's looking at that documentation, we're looking for time, how much time that practitioner has spent on that patient. And then the medical record can identify both the face-to-face time and then also the non-face-to-face time for that patient. Because it's still work your physician or practitioner is providing to that patient, even if they're not right in front of them when they're doing it. Next question.
All right. When using time for rounding charges in the hospital, does time spent with the patient's family deciding if hospice is appropriate count?
This is kind of a trickier one, okay? In the fact that information, when you're providing information back to the caregivers, to the family to say, this is what I'm doing, et cetera. That's not time necessarily on your patient. If you're having a conversation with that family to assist you in your medical decision making for that patient, then yes, you can count that time.
All right. With split share time with both the APP and MD providing documentation, but a scribe document, how are you to stipulate within the documentation of who provided the substantive amount of care?
Well, each practitioner is going to document what they did. And since we're talking about time, the nurse practitioner would have to say, I spent whatever, and the physician would have to say, I spent whatever. And then whoever has the most time, when you're using time, that's who would bill the service.
All right. Our next one's an interesting kind of unique scenario. The question is, can you bill a patient visit if the patient is not there? In this situation, the patient is a mentally challenged young man and the mother is the power of attorney. The family came in without the patient for chemo.
What was the last word you said, Rachel?
The family came in without the patient for chemotherapy teaching.
Okay. No, you would not bill an E&M in that situation. Medicare does have some new services that are payable beginning January 1st of this year. And caregiver training services is one of those. And we do have a webinar planned on that. It's not advertised yet. Hopefully it'll be out there next week in April, going over those caregiver training services. So no, you have to have a face-to-face with the patient for an E&M. You can also count non-face-to-face time, but have to have a face-to-face with the patient.
All right. So our next question is per CPT 99497 is one of the advanced care planning codes. It reads the first 30 minutes face-to-face. Does the provider have to spend at least 30 minutes per CMS to provide this service?
I'm not as familiar with the advanced care planning procedure codes. That one's one we'll have to do some research on. I don't want to answer because I don't know for sure. But we'll research that and then send it out to everybody following the presentation.
All right. So next one, can the provider enter a time range? So for example, can they document, I spent 30 to 39 minutes managing this patient's problems on this calendar date?
Again, this is one of those situations that you can, it's not your best practice. Again, that's more of a macro, it's more of a canned language than specific language. So I'm not going to tell you that it's incorrect because it's not. It's just not your best practice.
All right. So this is our final question. It might be something that we have to look into. But the question is, for lactation services, where both the mom and the baby are seen at the same time, each has specific issues addressed and separately documented. The total time is 60 minutes. Do we split the time? Can we bill time for one patient and the medical decision making for the other?
Okay, we don't have a whole lot of Medicare patients that receive that particular service. And what you would have to look at is the procedure code that you're submitting. If you're submitting an evaluation and management procedure code, okay, wait a minute, I got to think about this one because you've got both the mom and the baby there. If you're, okay, let's go this route. If you're going to bill separately, so for an example, you're going to bill Medicare for the services provided to the mom, you're going to bill Medicaid for the services provided to the patient or to the baby, then your documentation would be separate for both of those. If there's a different procedure code that you're using other than an evaluation and management code, then you would have to go with whatever the rules are for that particular procedure code. Next question.
So those are all the questions we have.
Okay. Okay, just as a reminder, we are going to be having additional webinars this month on problem, data, and risk. And again, it will be a Q&A like we have done today. So I do encourage you to sign up for those. All right, so thank you very much for your attendance today. On behalf of Rachel and myself, we would again like to ask you to complete that survey. We would ask that you take a look at those encore presentations that we have available. There's a lot of great information contained within those. You can use those for help in training your physicians and practitioners on these new guidelines so that they are being paid appropriately for the services that they're providing. Again, just as we stated earlier, don't leave money on the table. If your documentation supports the time that your physician or practitioner has spent on that patient, then you can use that time in order to choose your level of service. So again, we just thank you very much for attending, and everyone have a great day.